Swayam Prabha. Digital India. Educated India.
Hello everyone, welcome to the course on computer aided drug design. We will continue on the topic of solubility, then I will start introducing permeability. Solubility and permeability are sort of contradicting each other or conflicting. Solubility, we are talking about solubility in the GI, that means it has to have good water solubility, that means it should be polar. But when you talk about permeability, it has to cross the membrane, the lipid bilayer and reach the bloodstream. That means it has to be hydrophobic or lipophilic. So, it should have less of hydrophilicity. So, this solubility and permeability are always at loggerheads. So, we need to balance the property of the drug so that both are satisfied at the same time. That means it should have enough water solubility and then it should be able to permeabilize through the GI membrane and reach the bloodstream. Now many factors affect this solubility. Yesterday we did introduce this. If you look at the transit time in various parts of the GI, starting from esophagus, stomach, 30 minutes to 3.5 hours, whereas if you go to and then jejunum it could be 3 to 4 hours, okay. And then the surface area, if you look at, we call this small intestine 120 meter square, whereas stomach the surface area is very small, 0.1 meter square. The pH in the stomach is very acidic, 1.4 to 2.1. As we go down into the small intestine, we go to almost neutral and basic. So, most of the drug absorption should be taking place here because the surface area is very high. Colon, it is 1 to 3 days, surface area again is very low, pH is almost in the basic region. So, we are moving from highly acidic to basic and then low surface area, very high surface area, again low surface area, and as you can see the transit time also changes. So, one needs to consider all these if we are talking about drug absorption and drug solubility. So, we looked at what are the various strategies to improve solubility. We can do a lot of structural modifications, okay. Modify the log P, make it more hydrophilic, make it into a salt, add polar groups, okay, reduce the crystallinity of the material and so on. Or we can use carriers. Nowadays there is a lot of interest in drug carriers like nanoparticles, liposomes and so on, okay. Then we can use co-solvents, we can emulsify the material so that emulsion is able to dissolve nicely, or we can add a complexing agent, okay, so that it complexes with the drug and hence improve the solubility. These are strategies, but generally these three items do not come under drug discovery, they will come later, more of the pharmaceutics, whereas the structural modifications which we are talking about, we can call it a drug discovery process. So, adding ionizable groups, reducing log P, adding hydrogen bond, adding polar groups, okay, reduce molecular weight, out of plane substitution, I showed you one, so that the crystal packing is reduced, construct a prodrug. All these are various strategies which can improve solubility. Now when you look at dissolution rate, how do I improve the dissolution? So, it is not only it has to be soluble thermodynamically, but it has to also be quite fast because as you can see in stomach it is only 3-4 hours. So, if you want a fast acting drug, it has to dissolve very fast. So, dissolution is more of a kinetic. So, increase surface area. So, by increasing surface area of the solid, it will start dissolving fast or reduce particle size. Pre-dissolve in a solution, that means I can give a oral solution so that it is already dissolved in a solution form. Improve wetting of solids, that means we can formulate with some surfactants, salt formulation, all those things we can do that will help the wetting of the solid. So, these are some strategies for improving dissolution rate. Like I said, dissolution is a kinetic whereas solubility could be more thermodynamic. Okay, so generally drugs are manufactured as a salt form. 70% of drugs I would say are in salt form, and out of that 70% of counterions used in commercial drugs are anions, 30% are cations. So, anions we could have chlorides, sulfates, bromides in this order, chlorides predominantly drugs you will find lot of chlorides. If you look at cation, sodium salt or calcium salt or potassium salt and magnesium salt. So, these factors improve the solubility of the drug tremendously. Now, let us look at permeability. Permeability, that is the diffusion of these molecules through the membrane, the GI lipid membrane, which is highly lipophilic. Mostly it is through passive diffusion, okay. Very little of active diffusion that happens, mostly it is passive diffusion, and so that means we have to have the compound reasonably lipophilic so that it passively diffuses. So, it is a determinant of intestinal absorption and oral bioavailability, because your intestinal absorption and oral bioavailability depends on this permeability. If the permeability is very poor, like I mentioned, the drug could be solubilized, but it is not getting through the membrane, so it may get excreted, okay. So, that is a problem. So, bioavailability can be poor. So, many factors affect permeability. Generally like I said, passive diffusion is the predominant mechanism. Commercial drugs, even food, generally it is passive diffusion. So, there is always a competition between food and a drug, and they both start behaving in a similar manner during this permeabilization. Hence, that is why doctors sometimes say take the drug before food, take the drug after food, because they start competing for the same diffusion through the GI. So, some drugs may get absorbed by the food and or they may get prevented from passing through the GI membrane. Okay. Permeability is increased if I remove ionizable groups. If I have ionizable groups, then it becomes a polar compound, and like I mentioned, lipophilicity should be the factor which determines permeabilization through the GI. So, removing ionizable groups, increasing log P making it more hydrophobic, decreasing size. When you have smaller compound, it diffuses better than larger. Decreasing polarity, that means remove the OH groups and NH groups and so on. We look at some examples as we go down. Food and drug follow passive diffusion, like I mentioned. So, there is always going to be a competition when you take food and drug together, okay. That is why it is always recommended for different types of drugs when to take before or after and so on actually. So, this is a very interesting slide, passive diffusion across the membrane as against pH, okay. So, we are talking this very low pH could be the stomach, and it goes small intestine, large intestine and so on, okay, up to colon. So, we see that the passive diffusion decreases for say NSAID, non-steroidal anti-inflammatory drug like ketoproline. Another drug naproxen, again it goes down. So, that means passive diffusion is very good in the stomach region, okay, and it becomes very poor as it goes to small and large intestine. Whereas, if you take a calcium channel blocker, verapamil, it goes up with pH. That means the diffusion is much better down the line in the small and large intestine rather than in your stomach. And same thing happens here, a beta blocker like propranolol, the diffusion is much better, sharply rising at higher pH 6, 7 and all that actually, okay. If you look at caffeine, diffusion is very low, whether it is acidic or whether it is basic, and same thing with the epilepsy and neuropathic pain, carbamazepine. It is a higher number, but it does not change much with the pH condition. So, you need to understand this, what is the favorable pH for it to diffuse. As you can see, some diffuses very fast, okay, and in acidic condition some diffuses very fast in the basic condition, okay. So, that plays a very important role in the entire drug action as well as its viability. Okay, so we have predominantly passive diffusion taking place, then there could be transporters which may be collecting, specific transporters which may be collecting your compound and taking it across, and there is something called endocytosis, that is a mechanism. It is like gobbling up the food or drug or any compound, that is endocytosis. Simultaneously there is also efflux, that means whatever is inside is thrown out. This is a very important mechanism for the survival of the system. So, efflux transporters are there which throw out compounds which look foreign. Its idea is to reduce the toxicity inside, but it may throw out even your drug out. This is the efflux transporters. So, all these are taking place in a membrane system. These are the major mechanisms by which these things happen. So, endocytosis, like I said, is the active transport in which a cell transport molecules into the cell by engulfing, almost like gobbling up in an energy using process, okay. So, it does take up, whereas your passive diffusion does not use any energy. So, large chemical substances, polar molecules cannot pass through the hydrophobic plasma by passive diffusion. So, they have to go through either an active process or endocytosis, which is energy using process, okay, whereas your passive diffusion does not use any energy. So, permeability, several membrane barriers. We have the gastrointestinal epithelial cells, blood capillary wall, hepatocyte membrane, glomerulus, that is cluster of nerve endings, pores or small blood vessels, restrictive organ barriers, that is the blood brain barrier. We will talk more about this. There is a barrier which separates the brain from rest of the blood region, okay, to prevent toxins or viruses crossing and going into the brain. It allows only small molecules, glucose and oxygen. Then target cell membrane. So, the drug has to encounter so many membrane barriers before it reaches its target site, okay. Different membranes can have a different permeabilities, okay. Membrane lipid mixture, passive diffusion, membrane transporter active, tightness of junction between walls. Sometimes the junction walls are very tight, so they do not allow any diffusion to take place. Unless it becomes very loose, diffusion might not happen. So, different membranes may have different permeabilities, okay. So, permeability effects, what can happen? They can affect the bioavailability, because what is available at the target site of the drug may be very, very small, because it is not getting transported or permeabilized, okay. So, after oral administration depends heavily on permeability, of course, okay, and then compounds with low permeability have low bioavailability, that is true. On cell based activity assays. So, if I am doing any cell based assays, so if the permeability, pure enzyme based studies may show good drug activities, but when I am using cell based system, that is almost like an in vivo, and it may show poor activity because the diffusion of the drug into the cell membrane may be very poor. So, pure enzyme based studies may show very good positive results, whereas when you do a cell based in vivo studies, it may show a very poor result because of poor permeability. High enzyme activity and permeability are required to produce good bioactivity in the cell based assay. So, cell based assay permeability plays a very important role. So, what are the strategies? Convert ionizable groups into non-ionizable. Like I said, ionizable groups lead to polarity, so make it more non-polar. Add lipophilic group, that means your increasing log P. Isosteric replacement of polar group. So, if you have OH group, make it OCH3, NH group, make it NCH3, and esterify carboxylic acid. So, if you have acids, it can become polar. So, we make it COOCH3, like reduce hydrogen bonding and polarity. So, if there are any hydrogen bonding groups OH, NH, reduce them. Reduce the size, so the material can transport easily inside. Add non-polar side chain, or do prodrug, that means it is a complex, like it is not a drug, that means it does not have any activity. When it goes inside the body, it gets cleaved and the drug gets released, which may start acting as a real drug, that is called prodrug. So, all these effects, let us look at some examples. So, we have a ionizable group, as you can see there is an ionizable group, okay, and we are trying to convert that ionizable group. This is an endothelin 1 receptor. The permeability through this CACO2, CACO2 is the cells which from the stomach epithelium, it is very poor permeability, whereas when I reduce the ionizable group to non-ionizable group, because you have the acid here, so we can have O minus and H plus, we convert that into OH, okay, it does not get ionized. Look at the permeability, huge increase, okay, 500 times increase maybe. Add lipophilicity, that means make it highly more log P. So, we have this is a coagulation factor X inhibitor, okay, this is a coagulation factor X inhibitor, and you are adding a lipophilic group into this, okay, so that log P increases from 3.1 to 3.43, and oral bioavailability also increases, there is a extra CH3 added. So, log P increases little bit only, but look at this, the permeability has increased and the oral bioavailability has increased tremendously. Reduce hydrogen bonding, okay. So, we have groups, look at this particular molecule, it has got a OCH3, OCH3. So, obviously these are hydrogen bond acceptors, the permeability is 0.4 10 power minus 6, we remove that, permeability has increased dramatically. Reduce polarity. So, look at this. So, CACO2 permeability with fluorine groups 0.4, CACO2 permeability with chlorine groups, it has become 8.8, it is a big 20 times increase, okay. Reduce size, this is a huge molecule, look at this molecule. So, from 31 10 power minus 6, 9 10 power minus 6, 62 10 power minus 6, by having, look at these groups, okay. So, we can reduce sizes and increase the permeability through CACO, do you understand. Make a prodrug out of it. What is this prodrug? This is a precursor of a drug and it has to undergo a chemical conversion by metabolic process inside the body. During that process the drug gets released, that is the active pharmacological agent gets released, that is what is called a prodrug. So, the prodrug itself is not active, but inside the body because of the presence of enzymes. So, you may have ester groups or amide groups. So, that particular prodrug gets metabolized. So, the drug gets released and then it starts acting, okay, that is called a prodrug. So, you do a prodrug so that there is a good permeability of that, whereas the drug itself might not have good permeability because it may be very polar, hydrophilic in nature. Look at this, sulfasalazine, this is a prodrug in its ingested form. It has to be broken down by a bacteria in the colon into two products, okay. So, this is a particular compound, it is a prodrug. So, it is broken down, sulfa pyridine, sulfa, you have the sulfur group, sulfur dioxide, pyridine. This is an antibacterial to treat certain skin diseases, okay, whereas this one is a 5-amino salicylic acid. You can see the salicylic acid, an anti-tubercular agent often administered in association with isoniazid. So, look at this. So, this has no activity at all, but when it is broken, this portion is the sulfapyridine and this portion is 5-amino salicylic acid. So, this portion has got anti-tubercular activity, this portion has got antibacterial activity, but together they do not exhibit any activity. So, there is inside the body this particular bond may get broken, that is called a prodrug. Look at this, this is oseltamivir, this is an antiviral drug, it inhibits influenza virus neuraminidase, okay. It is an ethyl ester. So, this particular bond has to be broken by hydrolysis. So, if you have an enzyme inside esterase like it breaks this and then the remaining portion becomes an active material inside, okay. This is a prodrug. Benzapril, this is called a angiotensin converting enzyme inhibitor, okay. Angiotensin converting enzyme is used to treat hypertension and heart failure. Again this is a prodrug, this ester bond has to be hydrolyzed by an enzyme called esterase to make this drug active. So, it is easy to put in a ester group which will anyway break inside the body because our body contains esterases enzyme, then the active drug starts acting inside the body, okay. That is the strategy that is generally adopted. So, if you have a drug which does not permeabilize inside the body, then what you do is you put a functional group with the ester bond and it will generally break inside the body because of the esterase enzymes found, and then the active drug gets liberated, okay. So, that is this whole system is called a prodrug. The prodrug does not have any activity of its own. Fosinopril, phosphenic acid containing ester prodrug, okay. So, it has got a phosphenic acid, okay, this particular one that belongs to the angiotensin enzyme inhibitor class of medication, okay. And so, this has to be broken, it is rapidly hydrolyzed to fosinoprilate, which is the active metabolite which inhibits ACE, the enzyme responsible for the conversion of angiotensin 1 to angiotensin 2. AT2 regulates blood pressure. So, we do not want too much of AT2 in the body, and the AT2 is produced by the ACE enzyme, angiotensin converting enzyme. So, these drugs go and bind to ACE and prevents the formation of the AT2, okay. Again this is a prodrug, and as you can see this needs to be broken before the drug becomes active. So, different approaches we can do. So, lipophilicity is the most important physical property of a drug in relation to the absorption, distribution, potency, elimination and all that. It solubility, absorption, plasma protein binding, metabolic clearance, volume of distribution, enzyme binding, biliary and renal clearance, central nervous system penetration, storage in tissues, bioavailability, toxicity. So, many factors are affected by this lipophilicity, okay. Now, we have looked at the concept of solubility, we have looked at the concept of permeability, okay. Now, there are many other factors and they all come under the class of drug likeness property, okay. These are structural properties which determine in vivo pharmacokinetics and toxicity of a compound in the body, like ADME. A means absorption, D means distribution, M means metabolism, E means excretion, and of course nowadays they also include T into this, okay, that is called T toxicity. So, we can call it ADMET, okay. So, that is toxicity, ADMET, okay. So, if you take optimal clinical candidates, they should have a balance between activity and properties, that is very important, activity and properties. So, very active material, very poor ADME properties, then it cannot pass through the clinical trials. Very poor activity is also generally not good. So, it should have a balance between activity and properties. So, we looked at a couple of properties like the solubility, like the penetration or the permeability. There are many other properties like distribution, like metabolism, excretion, toxicity. So, we are going to look at each one of them in detail, because these drug likeness property determine whether a drug is going to be very good or not so actually. Okay. Now, so poor ligands, good ligands, so activity increases. Poor property, very good property, there is. So, ideally I should have very good properties and good activity. I may have good activity, but poor property. So, these are all failure compounds, whereas this could be success. I mean, this is the most ideal, but you may end up somewhere here also. So, that is also okay, that is also okay, that is also okay. This is the most ideal and this is not very good. So, the pharma companies generally look at this region also, but getting this is really a big blockbuster, but chances are generally you get somewhere here. So, you should have reasonably good activity as well as good property for it to have good bioavailability, less toxicity, less side effects, and so on actually. Okay. So, we are going to, as I said, look at all these various other properties in addition to the water solubility and permeability through the GI membrane. Okay. So, what are the properties, structural properties? Hydrogen bonding, lipophilicity, molecular weight. Okay. pKa is the acid dissociation constant, polar surface area, shape, reactivity. These are the structural properties which affect your solubility, permeability, chemical stability, because inside the stomach we are talking pH in terms of 2. So, your molecule has to be stable. When it goes inside your plasma, you are talking about enzymes like esterases, oxidoreductases, lipases. So, your drug has to be still stable in the presence of all these enzymes. So, stability also becomes very important, not only at different pH conditions, but also inside your body. And the biochemical properties are important. Metabolism, how the drug gets metabolized inside. Okay. Does it bind to the protein inside, does it bind to the tissues inside your body, how does it get transported, uptaken, all those become very important. And later on, clearance, drug once it has done its job, it has to come out, get thrown out, excreted. So, clearance is very important. What is the half life of the drug? That means the concentration in the plasma has come down 50% level. Then bioavailability, what is the concentration of the drug available at the target site? If you are taking 2 drugs, 3 drugs, is there a drug interaction? And nowadays there is a drug food interaction also coming into picture, because some drugs are not good with some food, and some drugs are get upregulated in the presence of some food. So, we need to consider this also. And then lethal dose, LD50 is lethal dose to kill 50%. So, all these effects also come into the picture when you are designing, and they are called the drug likeness property. Okay. So, this is a very interesting slide. We have the pharmacokinetics and toxicity, the clearance, the half life, bioavailability, LD50, the living system. Then we have the biochemical properties like metabolism, transporter affinity, binding, and then we have the physicochemical properties of the drug, solubility, permeability, chemical stability, that is the physical environment. So, we have the living system here, and then we have the physical environment of the drug, and then we have all the protein and all that actually. Okay. Compound structure, what I can change? I can change molecular weight, I can change the hydrogen bond donors acceptors, I can change lipophilicity, I can change polar surface area. PSA means polar surface area, pKa, that is dissociation, I can change shape, size, reactivity. So, all these I have control on, but we have to see how it affects the binding with the target protein, okay, and then how its toxicity is affecting in living systems, what is its stability inside, what is its excretion inside, and half life and bioavailability. Okay. So, we will continue more on this topic in the next class as well. Thank you very much for your time.